This conference will now be recorded.
Okay, so good evening, everybody. Today we'll be talking about the thyroid nodule. Uh, okay, so this is the disclosures and acknowledgements, and picking up the material from a number of sources on the internet, from textbook, journals, and chief among them being Bailey in the Love 27th edition, Short Practice of Surgery, and Sebastian Textbook of Surgery 21st edition. Now, let's define a thyroid nodule. What do we really mean by a thyroid nodule? And until quite lately, we had been given to understand that it's a clinical definition. But that is entirely wrong. The definition of a thyroid nodule is a discrete lesion in thyroid, radiologically distinct. Note, it is not clinical from the surrounding parenchyma. So we have a definition which is a purely radiological definition. As we go forward, I'll tell you why this is so. Seemingly palpable nodular swellings, if not radiologically distinct, cannot be considered as a thyroid nodule. So it is saying two things, that radiologically it has to be a distinct and solitary swelling distinct from the surrounding parenchyma. If it is not, then you cannot call it a thyroid nodule. So the definition of thyroid nodule is a purely radiological definition. So then what is the terminology that we've been discussing or we have been listening to until now? The clinically discrete may either be appear. Here, remember the word clinically is important. So clinically isolated or solitary, as seen in 70% of cases, the rest of the gland is not palpable clinically, or as a clinically dominant thyroid nodule seen in 30% if the rest of the gland is palpable or nodular. Now, clinical differentiation is not accurate, and that is why the true incidence of an isolated thyroid nodule is less than the clinical estimate. Is less than the clinical estimate. Okay. So what we are really saying is that what we are palpating clinically is not correct all the time. Many a time, what we are palpating as a clinically isolated may not be truly isolated. A part of it may be a swelling where there are other nodules. That is why the true incidence of isolated thyroid nodule is less than the clinical estimate. In other words, the radiological distinct thyroid nodule is less than the clinical estimate. Okay. Then the next term that we need to define is the incidentaloma. Now, what is incidentaloma? It is an incidental finding of a thyroid nodule on radiological investigation, whether it is an ultrasound, it's a CT scan, it's an MRI, whatever, of the neck, done for some other reason. Now, if you're doing it for some other reason and you're trying to find or you're isolating a thyroid nodule, then it is a incidentaloma. Now, coming to the epidemiology of a thyroid nodule. Now, the incidence is very variable. Clinically palpable, it is documented as 4 to 8%. Females to male ratio 3 to 4 times as common in females as in male. But let's look at the ultrasound, an MRI, and a CT scan would give an incidence of almost 20 to 70%. See the wide disparity uh, in the figures from 20% right up to 70%. That is a wide disparity. Autopsy finding gives an incidence of 50%. So there's a whole range of incidence of thyroid reduce, which being in the. I'm sorry, somebody's mic is on. Kindly please close the mic. Now, prevalence is seen, that means risk factors for a thyroid nodule are usually females in elderly, childhood, radiation exposure, iron deficiency or excess, cigarette smoking, obesity, autoimmune thyroiditis, and Graves' disease. Which basically means that in all these conditions, you are basically having increased incidence of a thyroid nodule. The malignant potential, 5 to 8% of all nodules, whether they're incidentalomas or palpable solitary or multinodular. See, this is important. Whether it is a solitary or it's a multinodular, doesn't make a difference. The malignant potential is 5 to 8%. But there's another catch to it. The figures in various sources are very, very variable. Love and Bailey gives a figure of 15% incidence of malignant potential. as compared to other studies which cite 4 to 8%, 5 to 10%, and similar figures. So again, we have got a wide disparity in reporting, but we'll stick to the figure of 5 to 8%, or if you want, to 10 to 15%, whatever. So that is the malignant potential. Now, what about an incidentalloma? Now, if you do a PET scan using 18 FDG, the incidental uptake of this PET scan would be positive in 1 to 2% of patients. Agree. That basically tells you that the incidence is really 1 to 2%. But 33%, that means one third of these patients are positive for malignancy. They're positive for malignancy. So does that give an added importance or a sinister importance to incidentaloma? We'll understand as we go further. Now, what are the causes of these thyroid nodules? After having discussed what it really means, let's see what are the causes of thyroid nodule. So benign in 85%, malignant in 10 to 15%. Among the benign causes, that means more for most of the time, it is for most part it is a benign swelling, lesser 10 to 15%, it is a malignant swelling. So what we're looking at is a adenomatoid or colloid nodule, a nodular hyperplasia, adenomas, and among all these, among the benign, almost 40% are follicular adenomas or Hurther cell adenoma. Follicular is most common. So among the benign, the most common cause is a follicular adenoma among the benign causes. Cyst, it could be simple or hemorrhagic or degenerative, or it could be part of Hashimoto's disease. Among the malignant, you've got the whole range of malignancy, the cause of malignancy or types of malignancy of thyroid, which we'll talk about in further slides. So if you look at the clinically discrete thyroid swelling, here I've written clinically discrete, important. 70% clinically isolated, 30% clinically dominant, and the word clinically has been added everywhere as a prefix because that gives a different meaning to the understanding of a thyroid nodule. So among these 70% clinically isolated or solitary among them, 15% would be malignant, 40% I just now told you would be follicular adenoma, and the rest 50% are other benign causes. So 15% malignant, the rest 85% benign. Among those benign, 40% follicular adenoma, that is almost half of the follicular adenoma. Among the benign causes are the cystic causes, either a total or a partial cyst, or you can have a colloid degeneration, or you can have thyroiditis, right? So that is the layout of a thyroid nodule. Now, after understanding this much about a thyroid nodule, let's see how do we approach a thyroid nodule. What is the clinical evaluation all about? And the first question which comes to mind is that when looking at a patient with thyroid nodule, the first thing comes to mind that is just not discussed is whether it's a discrete or a dominant swelling. Why? Because if it's a dominant swelling, we are probably looking at a different spectrum of disease, like for example, a multiple nodular goiter, where only one of the swelling is prominent, or we're looking probably at a Hashimoto's disease, where the whole gland is finely nodular and you find one large nodule in it, which can be clinically seen. So clinical assessment we just now said is incomplete. So if you're looking at a nodule, you have to look in for a radiological delineation. But the other important thing is, what are the concerns in a thyroid nodule? Why are you concerned about thyroid nodule? There are three concerns to it. Number one, whether it is malignant or not. So three C's: cancer, compression, and cosmetic. We're looking at cancer, the most important. Compression is slightly lesser important. Cosmetic would vary from person to person, so we'll skip the cosmetic part. And a fourth part which is added, the concern is whether it is a functioning nodule, either hyper or very, very rarely a hypo as seen in Hashimoto's disease. So we're looking at the cancer and compression as the two major concerns and followed by a minor concern of functionality of that particular nodule. Now, how do we approach this patient now? We take a proper history, that is very important. And what should the history be focused on? The history should be focused on the oncological aspect. Why? Because we just now said the first concern is whether we're looking at a malignant nodule or not. And for that, the higher probability of malignancy is seen in a particular group of age, less than 40 to 20 or up to 60 years, and then stabilizes after 60 years. Males more commonly are susceptible to a malignant nodule as compared to females, where the incidence of a nodule is much higher. Family history of a thyroid cancer, TC thyroid cancer, positive in first degree relatives, is a very, very important to be taken. We'll discuss that in the next slide. History of irradiation. Irradiation for what? For various indications like hematopoietic malignancies, stem cell transplantations, tumors of the head and neck, median channel, and CNS tumors, where you may be giving radiotherapy to that particular patient. And then, of course, a history related to the appearance and rapidity of progression of hoarseness, pain, or compressive symptom. That is very important. The second thing, the second part of the history is a part which would try to elicit whether that patient, the nodule has some kind of a functionality or not. That means whether the patient has features of thyroid toxicosis. When you talk about a younger patient with adenoma and functioning thyroid adenoma, these patients would be presenting with the classical symptoms of thyroid toxicosis like nervousness, weight loss despite increased appetite, sweating, palpitation, and so on and so forth. If the patient is elderly, then you're looking at more non-specific symptoms like anorexia, cardiac symptoms of atrial fibrillation, congestive heart failure. Rarely, as I said earlier, very, very rarely, you can have a hypothyroidism, which is hardly ever seen with thyroid nodule, except when you're talking about an autoimmune thyroiditis, and these patients will present with fatigue, constipation, and cold intolerance. Now, last slide we said a familial history is very important. So what about this familial history? First degree relative, if the patient gives a positive history of thyroid cancer, first degree relative, you are at a very high risk and you have to elicit that history from the patient. Most common form of familial thyroid cancer is the medullary thyroid carcinoma, most common. And familial medullary thyroid carcinoma can occur either as an isolated problem or more commonly as a component of the MEN syndromes. 95% of the time, it is associated with MEN2A, which is also known as PTC, pheochromocytoma amyloid proceeding thyroid cancer, or Sippel syndrome, which includes the primary hyperparathyroidism and pheochromocytoma. In only 5% of cases, you'll find an associated MEN2B type, right? The second is a familial papillary thyroid carcinoma, which occurs in 5% of cases. Occurs again as an autosomal dominant, inherited as an isolated form, or it could again be a component of a syndrome like Pendred syndrome or intestinal polyposis syndrome, where you got the FAP, the Gardner's, and Sutzkever syndrome. Follicular thyroid carcinoma can also be associated with a familial history, and there the usual association of syndromes is the Cowden disease and the Banyan-Riley syndrome. The Carney complex type 1 can be associated with either a PTC, which basically means a papillary thyroid carcinoma, or a follicular thyroid carcinoma. Werner syndrome, papillary, follicular, or anaplastic thyroid carcinoma. So you have a whole range of familial thyroid cancers, and that history has to be elicited from that particular patient. Continuing the history forward, now what do you want to know from the patient? Whether your nodule is painful or not. Normally, they are painless nodules. If it is painful, it could be a number of possibilities. One, it could be an anaplastic thyroid cancer nodule, it could be a lymphoma nodule, it could be a hemorrhage in a cyst, or it could be thyroiditis. Next, are there any compressive symptoms? Like, for example, dyspnea because of tracheal compression, dysphagia, esophageal compression, hoarseness of voice, recurrent laryngeal nerve involvement. What is the duration? The duration for which these symptoms have been present, and how fast have they progressed? So the rapidity of progression again gives a hint whether you're really dealing with a malignant problem or dealing with a benign problem. And then the final history for distant metastasis, which is found in almost 10 to 13% of patients, and the three most common sites of metastasis from any thyroid cancer, any, is lung, bone, and liver. So when it's present in older patients, distant metastases are associated with higher risk of death, and that has to be elicited from these patients, right? So you look for a history of lung involvement, bone involvement, and liver involvement. Now comes the examination. So you've taken that history, now you're looking at that nodule, and what do you look for the nodule? Now, normally nodules are either obvious or they can be palpated. There could be a scenario where the nodule is not palpable. So difficult palpation could be found, number one, when the nodule is less than 1 centimeter in size, the nodule is present substernally, it is a posteriorly located nodule, or it is a nodule in the thick neck, even up to 2 centimeters. These nodules may not be palpable, right? A single, discrete, isolated, or dominant, or multiple. Now, this is clinical because we are examining the patient. So, we're talking about a clinically discrete or a clinically dominant or multiple nodule. The third is what size is the nodule? And size probably does not have any bearing on the incidence of malignancy, but the size does have a bearing on the ultimate therapeutics. What is the consistency of the nodule? A hard nodule is more in favor of malignancy as compared to a nodule which is softer. A fixed nodule again points towards malignancy. Tenderness, we just now enumerated the causes of painful nodule, so they will present with tender nodules. So this part of the examination, the first part of the examination, you have to know what is this nodule all about. Then look for the size of compression and infiltration, without which the examination with thyroid nodule is not complete. So looking at the Pemberton sign, I'm not going to go into the details of what Pemberton sign is. If you don't know, look it up. You just raise your hand above the head, and then you look for filling of the veins. Anyway, vocal cord palsy can be seen either by indirect laryngoscopy. Of course, hoarseness of voice is there, but then can be confirmed by indirect laryngoscopy or even by a non-invasive ultrasound can confirm vocal cord palsy for you. And then prominent veins in the proximal part of the neck. Next comes the examination of lymph nodes, and you have to examine the lateral cervical lymph nodes and the central group. The central group is basically level 6 and deep down behind the sternum level 7. But the lateral cervical lymph nodes start right from 2A, 2B, 3, 4 and 5B. Remember that. These are the groups to which a thyroid can metastasize, malignancy can metastasize. So remember these groups right from 2A, 2B, 3, 4, 5B, 6 and 7. What is the size of these lymph nodes, whether they are fixed or not. And distant metastasis, examine the lung, liver, and the bone. Right? Now, once we have done all this, only then go ahead and start with the investigatory evaluation profile of the thyroid nodule. And there are a number of methods by which you can do that, which comes first, second, or third. But one thing which is very important is that whether TSH comes first or ultrasound comes first, these two are the primary evaluating investigations which have to be taken into consideration whenever you're examining a thyroid nodule. So always start with serum TSH, subsequent prognostic and therapeutic evaluation by a high resolution ultrasound. Armed with the information with these two investigations, now you have to decide whether I should do a FNAC or not. Now, the usual belief that every nodule you should poke in a needle and take a FNAC is wrong. Please don't do that. Every nodule does not require a fine needle aspiration. So there is a definite indication when a fine needle aspiration is really required in a nodule. And that's why you always start with the serum TSH, you go in and do a high resolution ultrasound and then FNAC. Much less commonly done investigations include a radionuclide nuclide scanning, which is usually I-123, but it's not usually easily available. So they take the help of iodine 131, a CT MRI, and a PET scan. Routinely not recommended. The investigations are the antibodies, the serum calcitonin, and serum thyroglobulin, which are indicated for specific types of malignancies. And then, of course, gene studies, which have now got a major role to play, especially in the indeterminate types of malignancy. And these gene studies include the 7 gene mutational panel, including the BRAF, and most important, the red gene group. Useful test in nodules with indeterminate cytology on FNAC. I just not told you that. And these genetic studies, they got a very high specificity and a positive predictive value. But unfortunately, very low sensitivity for malignancy. Right. So first, let's talk about the less commonly indicated investigations. We'll pass through that, then we'll go to the major investigation. So the first is the radionuclide scanning. I-23 is a preferred with a half-life of 13.2 hours, or technetium-99 M per technate with a half-life of 6 hours. Scanning indicated for functional evaluation of thyroid nodule. Now see what's written in red. Indicated only when serum TSH is low. That is the only indication of doing an investigatory radionuclide scanning. Remember that. A low serum TSH is the only indication for a radionuclide scanning. Okay. Now, both the isotopes are taken up, but the difference between the two isotopes is that the iodine is organified. That means basically taken up, and it forms a part of the physiology of the cell, where the technetium doesn't. Right? A functioning nodule is, so when you do a radioisotope scan, you can have either a cold nodule, that's hypofunction, a warm nodule, isofunction, hot nodule, or hypofunction. Now, 10% are hot nodules, and there's no risk of malignancy. So what do? You found that the serum TSH was low, and you do the radionuclide scanning, and now you interpret. So what should I do now? With a cold nodule, the chance of malignancy is 4 to 6.5%. The next investigation is immediately an ultrasound scan. Warm nodule, always benign, no risk of malignancy. Hot nodule, no risk of malignancy. Further evaluation may not be required. May not be required. One thing to remember here is the last line. Look at this. 5% of nodules that appear hot or warm on per technate, when these same patients are subjected to iodine 131 or 123 scan, 30% of them would be having malignancy. So, what we're trying to put across is that the iodine scan is a much better scan as compared to a technetium 99M scan. The other less commonly investigated required are the CT scan, the MRI, and the PET scan. And what's the indication? Why do we say less commonly? Because the indication is a clinical suspicion of advanced disease. In an early disease, they have got absolutely no role to play. You don't require a CT, you don't require an MRI, you don't require a PET scan. It's only advanced disease which requires it. And advanced disease basically means what? One, it could be invasive primary tumor, or number two, clinically apparent multiple or bulky nodal involvement. So, your large lymph nodes, you got invasive primary tumor. That is the time when you should start looking at these investigations. A combination of ultrasound and CT has a higher sensitivity than a pure ultrasound. A PET scan has been widely accepted as a modality which is required in detecting recurrences, particularly in non-iodine avid disease. Why do we say that? Because one of the methods of diagnosing recurrence is an iodine scan. But suppose your recurrent cells, the cells found in the recurrent, they are not avid for iodine. So what do you do then? So these are the patients where a PET scan will help you. That's why I said differentiated thyroid cancer, particularly non-iodine avid disease. So you have got a recurrence, non-iodine avid, do a PET scan. It is a strong predictor of poor outcome in metastatic thyroid cancer. Basically means that if the PET scan is positive, then that shows that the patient has got a poor outcome. The CT MRI is probably the most important among these less commonly indicated investigation, and CT helps in accurate delineation of the primary, accurate delineation of the neck secondaries. It also helps by imaging beyond the neck, where infraclavicular, where retropharyngeal, whereas parapharyngeal, whereas mediastinum, lungs. Everything can be covered by a CT scan. And in addition to all this, with the CT scan is very important when you want to plan any kind of treatment. That basically it will delineate the inferior border, the extent of the laryngotracheal, esophageal, or vascular involvement. The disadvantage of CT is that there is a small risk of precipitating hyperthyroidism. Why? Because the iodine content in the contrast, because this is a CCT. So when you're doing a CCT, the iodine contrast is used, and that may precipitate hyperthyroidism. That's one. And number two, if you have done this CCT with iodine, then you have to wait for 4 to 8 weeks if you're planning on any kind of radionuclide therapeutics in that particular patient. MRI is not so good. Why? It is prone to respiration artifacts and can be more difficult to interpret, and that's why the baseline is doing a CCT scan for advanced diseases. Now coming to the most important, and how should you proceed? The TSH, and you do a serum TSH. You can either find a low TSH or you can find a normal elevated TSH. If you have a normal or elevated TSH, you are looking at the next investigation at USG. A low TSH basically means that you've got an increased amount of thyroxine circulating in your body. So it's depressing the TSH. So if you got a low TSH, it's a suppressed TSH. If that is so, we just now said you should do a iodine 123 scan. I'm not going to go to this again. We just discussed that in the first slide. If you got a normal TSH or you got a raised TSH, a normal TSH radionuclide scan is not required. You don't do a RI scan. But if it's a raised TSH, again no RI scan. But what is required here is in both the cases an ultrasound scan. So that's why it's written a normal or elevated TSH ultrasound is required. Why in a raised TSH? In a raised TSH basically means that the thyroxine, circulating thyroxine is low. That's why TSH is low, is high. So when you got a TSH level of more than 2 to 2.26 milli international units per liter, It is a harbinger of malignancy 3 times more commonly as compared to a normal person. So a raised TSH, you've got raised TSH, you may be having or you may be more susceptible to malignancy if you got a thyroid nodule along with that. So both the conditions, an ultrasound is required. And that brings us to perhaps one of the most important, which is considered to be an extension of the physical examination and standard of care. So ultrasound is now considered as an extension of the physical examination, number one. And number two, standard of care. Why? Which type? High resolution, use of 5 to 13 megahertz probe frequency, scan the isthmus, scan both the lobes of the thyroid, scan the central and the lateral neck compartments for the lymph nodes. You're doing this, this is the standard of care. Every nodule should be subjected to USG without fail. Every 100%. So 100% do a serum TSH, 100% do an USG. Two very, very important primary investigations. So what are the advantages? Why USG has been said as an extension of physical examination, and why is it considered standard of care? One, it can characterize the parenchyma for you. Number two, it can identify cervical lymph nodes for you. The lymph node groups you already enumerated. It can help by guiding your FNAC, FNAC, ultrasound guided FNAC for the nodule or from the lymph node. Easily done. Non-invasive assessment of vocal cords. Hyperthyroidism with nodule, rule out MNG. You can see for multiple nodules. If the patient has got hyperthyroidism, you're looking at toxic nodule, do an ultrasound. It'll tell you whether there are really small nodules associated with that. So that is no longer a toxic nodule. It is basically part of a multinodular goiter. Incidentallomas, and most important, the characterization of the nodule, which is perhaps one of the most important functions of ultrasound. And what are we looking for the nodule? What are we trying to evaluate in the nodule? What does the ultrasound tell you? Number one, it tells you the position. Number two, we're looking at the size. Now, the parts which are written in red are basically parts which are pointers towards a malignant nodule as compared to a benign nodule. So if the size is less than 1 centimeter or more than 1 centimeter, the shape, the length and the breadth of the nodule, if it is taller than wider, more chance of having a PTC. Margins, where they're regular or irregular. Irregular margins, more in conformity with malignancy. Content, cystic, solid or mixed. Solid and mixed are more in conformity with a malignant nodule. Echogenicity, relative to normal thyroid parenchyma. So you can have a hyper, hypo or isoechoic. The peripheral halo, an anechoic ring which is seen around the nodule, either because of compressed thyroid vessels displaced by the nodule or a fibrous capsule. Then echogenic foci inside the nodule is very important. And we're looking at what? Microcalcification, less than 1 millimeter, punctate calcification without posterior acoustic shadow, which is a very important feature of diagnosis of malignancy by ultrasound. Or you're looking at a macrocalcification more than 1 millimeter. The vascular pattern of the nodule, whether the vessels are predominantly central or peripheral. And then a serial ultrasound for growth pattern is very, very important, especially in those cases where an ultrasound has to be repeated after a particular period of time. And what tells you that the nodule is growing? It is very specific. The rule of two, 20% increase. So I've highlighted two, 20% increase in at least two nodule dimensions, right? With a minimal increase of 2 millimeters or more. Okay, so you're looking at two nodule dimensions, that means two dimensions of the nodule, not two separate nodules. It is two dimensions in a nodule. Okay, so two nodule dimensions. So you're looking at, let's say, the length and breadth of the nodule. So these are two dimensions for you. 20% increase in these two dimensions with a minimum increase of 2 millimeter or more is when you say that the nodule is growing. Or there is a 50% increase in the volume of the nodule, even then you would say that the nodule is growing. Now, evaluating the thyroid with the ultrasound, what are the features that are found in various malignancy? Papillary thyroid carcinoma, very high specificity with an ultrasound. Ultrasound can tell you more than 90% of the time that yes, this is probably a high specificity, basically tells you it's not something else. A low sensitivity is the problem with an ultrasound and a PTC. But what are we looking for? A microcalcification, irregular margins, growth, and taller than wider shape. Classic form of PTC, MTC basically is medullary thyroid carcinoma and primary thyroid lymphomas. Again, you're looking at a hypoechoic. Now, when a particular nodule is densely cellular, it will give a it will give rise to what? Hypoechoic picture on an ultrasound. So, markedly hypoic associated chronic lymphocytic thyroiditis often poses a problem in the ultrasound diagnosis. Why does it do that? For the simple reason that when you have got this chronic lymphocytic thyroiditis, there are clumps of lymphocytes, right? Large deposits of lymphocytes, giving rise to what? Pseudonodules, and they appear as hypoechoic area, and then you start thinking that probably you're looking at malignancy. But no, they have got specific signs, giraffe sign or the Swiss cheese pattern, and they need not be routinely sampled. Now, why all this about the ultrasound? Because this is going to be an indicator when you should do a FNAC. Similarly, the follicular and the follicular variant of papillary thyroid cancer have got specific features on ultrasound. A purely cystic nodules appears like a stack of pancakes or puffy pastry like a Napoleon or spongiform appearance, and they are almost always benign. These are the features described on an ultrasound. And this is a very, very important table, and I think you should understand what this table means. So, whenever we talk about the thyroid nodule, we are looking at recommendations or guidelines by two specific group of surgeons or two specific group of thyroid surgeons. Number one is the American Thyroid Association, and this ultrasound forms the grading, risk stratification, and guidelines for FNAC. All the three based on ultrasound characterization, and it characterizes the thyroid nodule into five types: benign, very low, low, intermediate, and high. And what do we mean? We already described the features. I'm not going to go to the features again. But what are we looking at? In a benign, see, the risk of malignancy is less than 1%. Indication of FNAC not required. Don't do an FNAC in a benign nodule if you've got ultrasound feature. That means every nodule should not have a needle poked into it. Is that clear? The follow-up interval. So if you've got a benign cytology, and is it required in a patient of benign? No, it's not required. So we said FNAC not required. What about very low? Risk of malignancy less than 3%. When should you do FNAC? When the size of the nodule is more than 2 centimeters. Again, very important. Nodule size very important. So you don't do if you have got a very low feature of on ultrasound and the nodule is 1 centimeter. Please do not do an FNAC. For that, the nodule has to be more than 2 centimeters in size. And when you have the 2 centimeter, you do FNAC. You find benign, then you have to repeat after 24 months. That basically means 2 years. A low, similarly, 5 to 10% risk of malignancy. Intermediate, high, 70 to 90%. And here are the size of the nodules when you should, which should be subjected to FNAC. And it comes down to the minimum size is 1 centimeter, which tells you that any nodule less than 1 centimeter is probably does not require FNAC except in special circumstances. We'll come to that what those circumstances are, right? So this is the risk stratification by the ATA guideline. Now, the second group is the American College of Radiologists and the Thyroid Imaging Reporting and Data System, which gives the ACR trirat system, and that again is characterizing it into five groups: benign, not suspicious, mildly suspicious, moderately suspicious, and highly suspicious. Now, this is again a risk stratification. See what is it doing? It's giving you the risk of NAC. It is again giving you the indication of NAC and follow-up interval in benign cytology. So if you see these two figures, these three columns are exactly the same. See, these three columns are exactly the same. What is different here is the description. And as opposed to the ultrasound findings which we described here in this ATA guidelines, here it is more objective, and you have to add up points to get TR points. And what are these TR points? They arrived at by adding points of five variables. And what are those five variables of the nodule? The composition, the echogenicity, the shape, margin, echogenic foci. And these are the points allotted: 0, 0, 1, and 2. So the maximum you can have is 3 plus 2, 5, and 3, 8, and 3, 11, and 3, 14. So that could be the maximum. So based on the totality of these points, from 0 point to more than 7 points, you can have the risk of malignancy right from 0.3% to 35%. And indication of FNAC, see, not required at all in TR1, TR2. It's only required when you start having a mildly suspicious. And here also, see, more than 2.5 centimeter size. And here also, the basic is less than more than 1 centimeter. If the nodule is less than 1 centimeter and more than 0.5, these nodules should be followed. You should not do FNAC in these, right? And this tells you if you find the benign cytology on the first FNAC, when should you repeat the FNAC after what interval if you have a benign on the first trial, right? Now, the elastography, I'll skip through this. Evaluating the nodule, ultrasound is also helpful for the lymph node. And what about the lymph node? The lymph node features predictive malignancy, size more than 1 centimeter. The Solviati's index, which is basically the ratio of the long axis to the short axis, it should be less than 2. Punctate calcification, we already talked about that calcification, less than 1 millimeter size. 100% specificity for malignancy. See, very high. Presence of hyperechogenicity, mixed echogenicity, cystic changes, loss of hilum, which basically tells you distorted lymph node, and peripheral hypervascularity. Because no single sonographic feature is adequately sensitive for determining a malignant involvement. That is why all suspicious lymph nodes, that means the size of the lymph nodes may even be below 1 centimeter. And that's why less than 10 millimeter, smallest diameter, can undergo FNAC if you are suspecting malignant uh, involvement, right? Now, how do you do a FNAC in these patients? Always, no, why? What is the principle of FNAC? One, core needle biopsy, forget core needle biopsy. It is no longer advisable for any kind of thyroid disease or any kind of thyroid nodule. If you're looking at core needle biopsy, the only one indication is in a patient anaplastic carcinoma, that also stage 4. You just want to have a diagnosis and nothing more. So, core needle biopsy, obsolete for thyroid, right? FNAC every nodule is not required. I've been stressing that time and again. Nor is it desirable, especially benign nodules, because of complications. Single suspicious sonographic feature is not an indication of FNAC. That means suppose you find microcalcification and you say, look, I've got microcalcification, I should do FNAC. No. One single suspicious finding is not the reason why you should do a FNAC. Need for FNAC is to be guided by either the ATA guidelines, I just now showed you the first table, or the ACR trirat guideline, I showed you the second chart. Nodule less than 1 centimeter, I just now told you, do not usually require FNAC except in high risk patients. Lymph nodes, again, less than 1 centimeter is usually not required unless suspicious features are there. And reporting on FNAC is very important and done by the Bethesda system of reporting for thyroid cytopathology. The sensitivity more than 80%, mean specificity more than 90%. Right? Now, how should you do it? Preferably always ultrasound guided. Needle size 23-27. Specimen needs to be obtained from vascular area solid nodule or both. If it's got a mixed nodule, it should be both from solid and cystic components of a complex nodule. What is very important is that reporting should be made on a cytology sample that contains at least 6 groups. So 6 groups composed of what? At least 10 well visualized and well preserved follicular cells in each one of them, right? So that means you have to have 6 samples and each sample should be having at least minimum of 10 cells before you can go ahead and report on FNAC, right? An exception is you got a colloid nodule, you'll only be aspirating colloid, so that is an exception. You won't be finding any follicular cell there. And this is the Bethesda category and risk of malignancy in a nodule. Again, this category is 6, and you start from the non-diagnostic and go up to the malignant, right? Now, the description, I'm not going to go in the details of that. You can look this up. But what is important is that the predicted risk of malignancy based on an FNAC, that's also very important. And you go right from 1.4% to stage 6 when you got a incidence of 99% reported malignancy, right? Actual risk in excised nodule almost 94 to 100%. And what is important about this FNAC reporting of Bethesda category? It can form a prognostic criteria. You can advise the patient, look, you've got this stage and you probably will be having chance of malignancy is, let's say, if it is stage 2, it could be 3%, or you have stage 4, it could be 30%, right? And it is basically also helpful in trying to decide what treatment is to be done. Now, if you have one thing important to be seen in this chart is that if you got 3 or 4, that means undetermined significance or follicular neoplasm suspicious or follicular neoplasm. In these, either do a repeat FNAC, but more important, the genetic or molecular testing is required in these patients or surgery. Why do we surgery? Why do we say surgery? because remember, for diagnosing a malignant follicular, you should have to have what? Tissue, not FNAC. And for tissue, you have to excise. So that means you have to excise the nodule, send it for histopathology. Only then you can say whether you're really looking at a malignant follicular or a benign follicular neoplasm, right? So that is why surgery is done. So you do a repeat FNAC with molecular testing, or you go ahead and do a surgery in these and send it for histopathological examination, right? Now, summary of management of thyroid nodule based on the Bethesda category. And in the first one is what is the non-diagnostic. We just now showed you in the first chart. And here the management is repeat FNAC under ultrasound guidance. Stage 2, no surgery. That was a type 2, benign, no surgery required. The stage 3, that is basically the ATP of undetermined significance or follicular lesion of undetermined significance. In these follow-up or surgical excision, I just now told you why it's required, because only then you can have a diagnosis of malignant follicular nodule or follicular nodule or suspected follicular nodule or Hurthle cell nodule or suspected Hurthle cell nodule. A thyroid lobectomy is required. Remember, follicular, it is a lobectomy to start with, unless until you are sure preoperatively that you're looking at a malignant follicular. Type 5 and 6, it is always total or near total thyroidectomy, which is required. That is suspicion of malignancy and malignant. It is basically the treatment advice is total thyroidectomy. Now, just a few words about thyroid cysts. 30% of solitary thyroid nodules are either totally or partially cystic. 50% of cysts are colloid degenerative cysts. Remainder are what? Involuted follicular adenomas. 10 to 15% of follicular cysts are malignant. 30% male, 10% female. There are some of the figures which you probably should remember, because that would give you a clear cut. If you're seeing a thyroid cyst, that gives you a clear cut idea what you're looking at. Papillary carcinoma can also present as cyst. And if you got a cyst, the best treatment possible, once you have determined it is benign, just do an ultrasound guided aspiration. If it is complete disappearance, that means totally cystic, you don't need to do anything else. But once you've aspirated and you find that there's residual solid component, that is when the alarm bells should start ringing, and that solid component should be properly investigated with the further investigation of FNAC and subsequently. If you got a recurrent cystic thyroid nodule with benign cytology, that means cystic thyroid nodule, benign cytology, you can do what is now known as a percutaneous ethanol injection or PEI, which causes coagulative necrosis and small vessel thrombosis. Or you can go ahead and do a surgical excision. What about a toxic adenoma as a thyroid nodule, a really solitary toxic adenoma? Now, these solitary may be part of generalized. We just now said you have to rule that out, that we are not treating with the MNG. But now when we come, now we understand it's really a solitary toxic adenoma. We understand that it's an autonomous nodule. That means you would have a high circulating thyroid hormone. Suppressed TSH and surrounding normal thyroid is thus rendered totally inactive. That means only the adenoma, the toxic adenoma which is functioning, the rest of it has been depressed by the suppression of the TSH. And the treatment is simple. Either the best treatment is surgery, do a lobectomy or a stomectomy, wherever the nodule is, the toxic nodule is better. It is easy, low morbidity, and curative. Surgery, all advantages, and less than 1% failure rate. The second option that you have with the toxic adenoma is a radioactive iodine 131, and the half life is 8.02 days. Therapy for older age group patients, in those where surgery is contraindicated, you can go in for radiotherapy. But the problem with this is that the failure rate is almost 6 to 18%, and recurrence rate is 3 to 6%, and it is contraindicated in pregnant females. Now, I think I will finish this off today, because thyroid malignancy itself is a large this thing. I don't know whether you are happy with continuing with this. Should I continue with this, or you want me to stop here today? We can cover thyroid malignancy some other day. Anybody with would like to voice his opinion? If somebody likes to put on his mic and tell me. Nobody wants to tell me. Okay, so I think we will finish it here today, and we'll continue with the thyroid malignancy some other day. Okay, thank you for your time. If you have any questions, you can always get back to me.